Dr. G. Gangaraju origin on the topic, which is the theme of the conference, KAUSALA VARDHANAM Excellence Through Skills. Of Pediatrics, Dean Sri Ramachandra Institute of Higher Education and Research Institute. And Dr. Margaret Shanti Ma'am, Professor and Head of the Department Pharmacology, CMC Vellore.
Guru, Chairman of ASRE Society, a founding father of ASRE Society, focus of change in and around West Godavari, and Lalia Nutraceuticals and Aquacultures, paper mills, sugar factories, educational institutes, and drug discovery. National awards for a best in-house R&D, best exporter, and multiple patents to his name. Champion of education and empowerment of the underprivileged, destined to approach in each venture. Supports of 100 Eco-Padya tribal and rural schools and VKDPS College for tribal and rural students. Compassion is the base of morality and education gives its wings.
To deliver this oration, it's my pleasure to introduce Professor Krishna G. Seshadri, a graduate from Madras Medical College, Internal Medicine from Illinois Masonic Medical Center, Chicago, Fellowship in Endocrinology at Cook County Hospital, Chicago, Senior Consultant Endocrinology and Diabetes in Apollo Hospitals, Chennai, and Senior Clinical and Research Lead, Apollo Sugar. Curricula and Guidelines for the MCI in 2011, ADCOM module, member of the Postgraduate Curriculum Group of Endocrinology, and CARB Teaching of Communication, Attitude, Responsiveness, and Values to Everyday Teaching. This is only a bird's eye view, and I would fail in my duty if I do not add this. If Krishna is here, education is along. He is a brilliant teacher and an educationalist, an extraordinary endocrinologist, a compassionate doctor, and a very good human being. And to many of us, the guru and the wise person who's been advising us at every stages, whether it may be in academic or non-academic. And it's my real pleasure to introduce him and invite him for this oration.
Lata Madam and Margaret Madam will be presenting the medal to sir. A big round of applause, please.
Lata and Shanti. It's already very cold here and you made it even more colder for me. But I'm here to pretty much deliver a lot of bad news. Because unless we have the ability to stomach the truth, we will never change. So if I offend some of you when I speak, it's because I intended to. It's supposed to hurt you. I will hurt you, and hopefully through those wounds, some changes will occur in the way we do it. When Dr. Srinivas talked to me about, and Dr. Vivekanand talked to me about what should we focus on the APUMEDCon this year, I said I want skills to be discussed. And the reason is a lot of bad news that we already have. Let me start with that. Please. Now, I think somebody just before me spoke about a perception issue that we have, right? And This perception issue is not anything new. This is Nilakanta Dikshita in the 15th century saying this. He says, Vaidhyaraja namastubhyam, Yamaraja sahodara, Yamastu harati paranani, Vaidhyo pranan dhanani cha. Oh Yamaraja, oh Vaidhyaraja, which is basically all of us doctors here, namastubhyam. Let me prostrate in front of you. You are the brother of Yamaraja. Yamaraja Sahodara. But there's a difference. Yamastu harati pranan. That is, Yama takes my life away. But oh Vaidhyaraja or doctor, you take my life and also give me a bill for it. So this perception issue is not anything new. This perception issue is almost 400 to 500 years old at least. But the consequences of this perception issue has widened because of the social media era that we live in. But also the inability of doctors to adapt themselves to the expectations of a society that demands different things from them. That they don't want the paternalism that was the hallmark of a physician 15, 20, 30 years ago. This is something that I keep talking everywhere, that what is the problem with medical education? I think the first problem that we have, and people who've heard me in other orations will understand this, we are pitching it too high. That we need to teach medical education. We assume too much when we teach medical education. And I quote N. Narayanamurthy. So I quote N. Narayanamurthy a lot when I do this. Hello? Yeah. I quote N. Narayanamurthy a lot when I talk about this, and that is, N. Narayan about 20 years ago said something that nobody liked. He still says a lot of things that nobody likes, but it's worth listening to him. What N. Narayan said was that 75% of the engineering graduates who come out of engineering colleges in India are not client ready. That they cannot be employed. People got very upset, but it's the truth. But I'm going to tell you, 100% of our graduates are not client ready. They're not ready to see patients. It's not like the United States where you can't go and see patients unless you finish a residency. An MBBS graduate is expected to see patients, and I promise you, our graduates are not client ready. I'll show you data. Our graduates are not employable either, right? Then we teach illness, not wellness. We continue to teach colonial medicine while the West has already appropriated our traditions. The future is here, we are not. I'm going to talk about the first three parts, and I've combined it into this oration today. Now, when I talk about machine learning, I do a lot of workshops in artificial intelligence and machine learning for physicians. And the first thing that when I ask them, will you be replaced? But let me ask you, how many of you think you will be replaced in the next 10 to 15 years? You don't think you'll be replaced? I promise you, you will be. Starting from the basic sciences, all the way up to the clinicians, none of you are expendable. Now immediately all the doctors will say, you know what? No machine can learn empathy. Right? Wrong. In fact, this fantastic article that was published in JAMA some time ago compared a patient's responses to how empathetic a doctor was versus a chatbot. And very interestingly, they rated the chatbot higher than the doctor. So if you think that your empathy is going to save you, I can show a machine learning robot that is much more empathetic. So anybody thinks that their job is permanent, think again, it's not. we are all at the risk of being displaced by technology. I had this beautiful debate with Sanjay Levin 2 weeks ago in Mangalore, and I can tell you that we will be replaced. Now, I've been doing this survey for the last 2 years. I still haven't got to publish it. I will publish it. I've been just talking to Avinash that I should do this. I first did this 10 years ago before we start rolling out CBME in some medical colleges, and then I've been doing it both nationally and in other medical colleges in this country. Asking students who are graduating and their teachers whether they can do a few skills independently when they graduate. Right? This is a national survey. This is a survey from another 4 medical colleges asking some simple questions. Do you think you can counsel and administer a vaccine independently? Focus on the blue. This is because it tells you I am trained to do this and confident of doing it independently. Less than a third of students tell me that they can administer a vaccine and counsel for it independently. Remember, these are graduating students. And roughly, only a third of their students, their teachers also felt that they are confident that their students can do it. By the way, you think that MBBS students should be able to give a vaccine? Should an MBBS student actually be able to conduct a delivery in a resource limited setting? Because that's really what their logbook is signed for. Less than 20% in most places will tell you that they can do this. And I'll tell you the bad news after this. And the same amount of their teachers think that they can do it. So it's not that the teachers don't know. They pretend not to know. Start an intravenous line independently. This they have learned from their senior house surgeons, and therefore about 40 to 50% patients of students say I am trained and I can do this independently. Can I write a death form, declare death, examine death and write a death certificate? Again, something that they should be able to do independently, yes. Am I asking for any great things? No, it's simple stuff. Less than a third of students can do this independently. Ability to give contraceptive advice, which is what the government of India has been spending money for years and years and years in the family planning program. Less than 30 to 40% of our students can give contraceptive advice. And their teachers are also living in one strange world. Another simple skill. Administer local anesthesia and suture a wound. Guess what? Anywhere between 30 to 45%. This is how, can I use the word pathetic, that our situation is. That is why I said I'm going to offend you when I start this. Ability to manage illness in a community. They are supposed to be primary care physicians. Less than 20% in most cases. Ability to function as a primary healthcare medical officer in a primary healthcare center independently, which an MBBS doctor should be able to do. Highest was 40%, lowest was 10%. Their teachers did not think it was even possible. Less than 25% in most cases, the teachers thought that they can function independently. So, where is this medical education that we are talking about? The primary purpose of medical education, if I remember right, because we helped write that definition, is to create a physician of first contact who is locally responsible and globally relevant. All our people are globally relevant because they pass USMLE and others and go away, but they are not locally responsive. We think this is a perception mismatch. We think that we are some great thing. This is the reality of medical education. Offended? Or you think I've spoken the truth? Okay. I will give you the worst news in all of this. Reality is starker than perception. In some of these medical colleges where I actually was doing a workshop, I called up the students who said that they are confident, took them to a skills lab and gave them the same set of 5 skills. Guess how many of them were able to do it independently? None. Even the ones who think that they are able to do it, when tested, they're not able to do this. This is the stark reality of medical education today. Right? Now I'm going to ask you, how many clinicians are here? How many of your students have been observed by you taking a complete history and physical exam? How many percentage of your students? 100%? No. 50%? No. 20%? Probably one teacher will raise their hand and say, I have seen. But the real truth is, none of our students in most institutions have ever been observed taking a history or a physical examination. This is the truth. You like it or not, this is the truth. It's throughout the world. Are you surprised? You shouldn't be, because we are all part of the system. So what is going on here? The purpose of undergraduate medical education is to develop a physician of first contact who can provide safe clinical care of an acceptable standard for the rest of his professional life. There is no other purpose. It's not to make him a scholar, it's not to make him eligible for NEET, it does not make him eligible for USMLE, nothing. It's not to make him an anatomy professor, certainly. It is to make him a safe physician of first contact who can provide safe clinical care of an acceptable standard. There is no other purpose of undergraduate medical education. We have assumed that just because we have placed students in an environment where patient care occurs, that they are for 3 hours sitting in a clinical area, that they will acquire the necessary skills for patient care. It's like sitting in front of Dakshinamurti, he is silent, he is just shown one finger, and we are all Sanakadi Maharishis who have become Brahmagyanis. Nonsense. We have assumed wrong. We have assumed wrong. When I say we teach medical education at too much of a level, this is what I mean. In the 3rd year, we think they don't know enough basics. In the final year, we think that they don't know enough clinical skills. Both times, we do not take the effort required to ascertain that they get these skills. And of course, medical education units are only filled with basic science people. Clinicians think that they are beyond all of this. What is going on here? We have allowed students to graduate without ascertaining if they have acquired the skills necessary for safe patient care. By doing that, we have put both patients and the graduating students at considerable risk. Patients will have bad outcomes, and the graduating students will be beaten up by society. This is the truth, like it or not. And this mad rush to graduate everybody, right? I remember very interestingly in 1998, when Harvard first came to the institution that I was working with, and they were doing a survey with this thing. And very interestingly, my mentor, Tom Arets, asked, how much % of you people graduate? And I think he was already dean at that time, very proudly got up and said, 97% of our students graduate. I was thinking in my back, this man's getting into trouble. Then Tom got up and said, if 96% of students are graduating, you have set your bar too high. In Harvard, less than 50% of our students graduate. Right? So this is what has happened. What is going on here? We have postponed acquisition of skills which should have been a gradual ascertainable process to a year of internship where they are least supervised. In other words, we expect learners to learn these skills in a year that they are mostly unsupervised or supervised by just a graduated senior house officer or a postgraduate. Which means you're learning the wrong things from a person who has learned it from another person, who has never been observed doing the right thing in their whole life. This is the stark truth of medical education, including our teachers. Oh, we learned so much from your teachers. I want to know which of your teachers ever taught you this is how to take a history. Not mine. I have wonderful teachers, but none of them ever taught me that. And if you ask our teachers, they will tell you, my teacher also didn't teach. So we all learned the wrong things. What is really happening is, this is what is happening. Whatever time in the morning, the medicine OP, the final year medical student runs into the OP with her friend. The assistant professor is sitting at the desk. He looks at her and gives her a grunt. Meet the second year PG has picked up a patient for you. She grabs her bag, runs to the PG. In the small teaching room in the back, there's a visibly uncomfortable woman on the table. The PG walks and says, found this examination case for you. Chief will be here by 8:30, and as he leaves, he whispers, concentrate in the aortic area, this is multivalvular. Happened? The student and their friend grab equipment from the bag, start asking questions from the list. Other students join them by 8:30. There are over 30 students in the small room, including students from other levels. And then at 8:45, the chief comes, he has sent this person, he said, multivalvular. The student starts presenting, and 2 minutes later, the chief starts taking a theory class. That's really what is happening. You can deny it, but this is what is happening. I'll tell you a very interesting story. This happened in Andhra Pradesh. About 10 years ago, at Pinamaneni Siddhartha, I say it because I think there are enough people from Pinamaneni even here. Dr. Nagesh Rao asked me to do a workshop on clinical teaching. He called me the day before saying, sir, our medicine chief feels, why is an endocrinologist coming and teaching on effective clinical teaching? He said, don't worry, sir. I remember this very vividly because I think Lata and Chalam and Damodaran were also there because they had joined me as faculty members. We started the lecture, and then I came, so I said, don't worry, we will get a student. First, sir, well, let us all observe this. We got permission from the student. We got permission for a patient to be brought. This student presented a fantastic history. I kept quiet. This professor from somewhere took a beautiful class. It will be one of those classes that you have imagined how professors take. Multivalvular, aortic, this happened, that's happened. I waited quietly, and he said, how? And everybody clapped, all of that happened. And then I said, sir, with your permission, can I do one thing? Yes, sir. He said, sir, can you please sit here? I'm going to ask the student to take a history for this patient. What the student presented and the history that the patient gave had nothing to do with each other. And when you examine the patient, there was nothing that the patient had the student presented. This is the truth of our examinations. Even in our exam, what happens? The examiner is sitting there. He's having murku and cashew nuts. The student is examining the patient there. Never once in our examination does the examiner go near the patient and say, can I ask you to examine this patient? Can I see it? Can I ask you to take a history? Can I see it? Can I ask you to counsel this patient on the medications he or she has to take? Can I hear it? No examination, it's only theory. So, how do we get to show some? What is really happening is if there's a training session, there's no supervision. There is no practice time. There is no feedback. There is no observation. The failure in clinical departments is the lack of observation. Really, how do you do outcome-based education? If I had to go back and rewrite it, I would remove the word competencies and just replace it with outcome-based. In fact, Avinash and I have had this discussion many times that we should just use outcome-based medication. But we follow the Western god of Xerox and therefore we use competency. But really we should use outcomes. That these competencies are determined to the vision and mission. The outcomes are stated and communicated. An environment is created to achieve the outcome. The achievement of the outcome is ascertained and documented. Some of you will know these pictures before, right? The proof of acquisition of selected competencies, achievement is determined, standard in a periodic assessment, and documentation is required, right? And ultimately, unless you have achieved it, you should not go for a summative exam. That is the truth. But this is what you want to do. That any skill requires an assessment of the prerequisite knowledge. A new skill is taught. But this is where we lose the plot. You need to create an environment of practice, review by the peer or facilitator and improve skills. And the skill needs to be assessed before the student is allowed to go to the next level. We fail here miserably. Right? The purpose of clinical teaching, what's the purpose of clinical teaching? Not to tell me 57 causes of hepatosplenomegaly because ChatGPT will give you 5 more. Not to impress the student with the kind of questions that you ask, but to find out and teach what is essential for saving a human being's life. The purpose of clinical teaching and training is the expertise of the care of the patient. If learning is the acquisition of new knowledge, skills and attitudes, and teaching is providing the opportunity for that to happen, we don't create that opportunity. Observation is the beginning of understanding. I'm going to spend 1 minute on this. Please bear with me because I think most of the people who know me know this slide. It's my most favorite slide about clinical teaching. George Engel said this: if musicians learn to play their instruments as physicians learn to interview patients, the procedure would consist of presenting in lectures or maybe in a demonstration or two the theory and the mechanism of music producing ability of the instrument and telling him to produce a melody. The instructor, of course, would not be present to observe or listen to the student's efforts, but would be satisfied by the student's subsequent verbal report of what came out of the instrument. This is exactly what is happening in medicine. How does a man teach music? Practice, sadhana, in front of me. No, this is wrong, do it again. Go home, practice and come back. What do we say? I will eat cashew nuts, you see the patient, you come back and see me. Correct? As I said, I'm going to be offensive. Students need an environment in which their beliefs, attitudes and behaviors can be observed, analyzed and challenged. If you don't do that, you're doing them a disservice. They want observation. So what can we do? First is utilize the clinical postings effectively. In most postings, 18 hours are available each week. With exceptions, the majority are glorified theory classes. You give it, the students are loitering around the hallways. If the class gets over at 12:30, the person comes at 12, and 12 to 12:30 there's a theory class. That time should have been used for observation and teaching clinical skills. It doesn't happen. Rework the clinical postings to ensure that learners are taught, observed, assessed, corrected and reassessed until they achieve an acceptable level for care competency in the basic and critical skills. That includes taking a history, that includes checking a glucometer, taking a blood pressure. Oh, they should have learnt in physiology is not the answer. So, how do we do it? First is, don't go from this end to that end. Use an incremental approach. Promote shared responsibility. Create learning experiences, and we'll talk about it. So, those of you who know our work This is the criticality feasibility matrix. What is critical needs to be directly observed, closely observed, one-to-one. What is not critical, not feasible, like 56 causes of hepatosplenomegaly are really not necessary. A chatbot can treat that. The senior most person must be teaching the most important of skills, which is history and physical examination. You don't need a professor to observe. You can pair up people and say, here is a checklist, observe. Higher phase students can teach lower phase students. Residents can teach students. Nurses, I can promise you, I learned critical care only from nurses. I had a wonderful bunch of Filipino nurses in our ICU. I learned how to intubate, how to take care of a wound, how to give a center line from all my Filipino nurses. Today, and one of the reasons you have a workshop on standardized patients is because I insisted on it, that the workshop should be on standardized patients, because today, with the number of patients and patient privacy issues, unless you create standardized patients, not every student can learn. Then, a simple camera is a great way for students to observe, learn, reassess, correct, and certify. Skills lab, we were talking how difficulty we had in writing the skills lab this year. But also, our students should be told, you are responsible for your own learning. I remember a discussion where a teacher used to keep saying, our children, they're not your children, they're adults. Treat them like adults. If they don't respond, they don't move ahead. It's as simple as that. Patients' lives are far more important than you need to be popular. I won't go into this, but remember, today technology can teach you a lot of things. Lastly, use the logbook. The logbook is filled with so many knows-how competencies that it has lost its purpose. The logbook is for skills. Skills that need to be acquired go into the logbook, and without it being acquired, no student goes for an examination. It's as simple as that. All competencies that are P and all SH competencies belong in the logbook. Reflections don't belong in the logbook, they belong in a portfolio. Reflective is a good way to ask people to write essays, and today what has happened is, you ask them to write reflections, so ChatGPT writes a reflection, and I know of teachers who use ChatGPT to correct it also. So ChatGPT writes to ChatGPT and nothing else happens. I won't get too much into this. But the most important thing is giving them an environment to practice. When I go to institutions and I ask, how long is your library open? 7 o'clock, sir. Okay, fine. How long is your skill lab open? It's mostly long. Just like a library needs to be open for 24 hours, a skills lab needs to be open for 24 hours. For people to go there and train. If you don't do that, to go there and practice, to do those things, if they don't do that, then there's no point in saying we have a skills lab. So, I'm going to close here. Is there anyone who's not offended here? I think I've tried to offend almost everybody here. But the idea is this. We can keep saying that we have improved so much and done this, and we when I first started a medical education program in our institution, a curriculum reform program, I put a moratorium on all the people who worked with me. I said, nobody will publish anything, because we get too carried away by publishing so much, we forget to work. So till the first rollout of our curriculum, none of my team members could publish. I didn't publish anything either at that point of time. But what is important is to get work done. Our most important work is to make people ready for patient care. You touch your hearts, you realize that we have failed in our work. It doesn't call for much, it just calls for us to rededicate ourselves to doing the basic things right. We have fallen for the PhDification of medical education and do a lot of fancy stuff. What we really need to do is to go back and do what is the kindergarten of medical education. Talk to patients, listen to them, take a history, do simple things, then we won't be Vaidya we will be Dhanvantari ourselves. Thank you so much.
More precise and observation as well as monitoring and giving a feedback to every student if we have to make them to be confident in handling the patients.
Thank you, sir. It's a really eye-opener about the new CBME curriculum, how the teacher also have to spend more time, especially in the clinics. It's so important that how we can see the improvement.
It is really true that we need to reflect once more, each day, every day, unless we realize that the skills that we are teaching is not getting learned by the learners, we are only glorifying ourselves. Thank you so much, sir, for this beautiful keynote address. And to give a token of our respect, we call upon Dr. S. Venkata Venugopal Raju, sir. A big round of applause. Sir is the Vice Principal Academic at ASRAM and also the Professor and Head of Physiology. Sir, please. We also ask our chairperson madams to join. To Krishna Ji Seshadri, sir. A big round of applause for sir. A certificate. As for the chairpersons also, please, Venugopal Raju sir, please give a memento to Lata madam and the certificate. A round of applause for madam. A round of applause please for Margaret madam. Thank you. Thank you madams and sirs for being with us. Thank you.